Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facillitator.
All right, well, good morning to anybody listening to this recording. We did this lecture a few weeks ago, but we had some issues with being able to record it because of my Wi-Fi and Dr. Uvoh's Wi-Fi. So here we are doing it again. So today I want to talk about immediate implant provisionalization because according to me, replacing a missing tooth or teeth with implant restorations is much more complex than simply placing a dental implant, taking an impression 2-3 months later and restoring it. I think a very critical factor in achieving optimal aesthetics, function, as well as periodontal health is developing the emergence profile of the implant restoration. Because at the end of the day, the success of an implant restoration, especially in the anterior, to me, should be that it should be perceptible to the eye the same way as the adjacent natural teeth. And a well-planned and well-executed provisional restoration is key in developing the shape of the peri-implant soft tissues. I want to say I will be discussing different, products and whatnot that I have used, but I absolutely have no conflicts of interest with any of those systems or any financial disclosures to declare today. What I'd like to do is be able to talk about when and why should we consider implant provisionalization, and then focus a little bit more on immediate implant provisionalization and placement and provisionalization, talking about biological and biomechanical considerations, how to really develop the emergence profile and the contour management, and what are some of the essential considerations behind this. And then I'm going to discuss several techniques that are available to us today and focus on what I commonly do, and then also talk a little bit about alternatives to a full provisionalization in situations where you cannot provisionalize an immediate implant, immediately placed implant. So the answer to the question when and why, of course, is when you are placing an immediate implant. So let's say you have a tooth that you know must be extracted for any number of reasons. It's non-restorable. You've taken the tooth out. You decide that it is a good surgical site to be able to place an immediate implant. Now you can see the soft tissue morphology that is present right now around a fresh, extraction socket is something that we would really like to be able to preserve in the long run, or improve from where we have it with the tooth. So that is one of the key reasons to me for wanting to do an immediate provisionalization. As you see in this photograph on the very right, this was a CADCAM milled provisional that was inserted on the day of the immediate implant placement. And you can see that the soft tissue morphology is maintained in a very similar way to what we had when the natural tooth was there. And now I'm sure you can imagine if we had on the day of the implant placement placed, one of the circular healing abutments, all this interproximal papilla and as well as the buccal contours that you can appreciate here would have entirely collapsed. So preserving and improving soft tissue morphology is one of the most important reasons for me to immediately provisionalize when I'm placing an immediate implant. And of course, patients' comfort and satisfaction with a fixed provisional rather than them having to wear an SX retainer or a removable partial prosthesis of some sort, which is again not desirable to me because of what it would do to the soft tissue there. And of course, in the long run, it reduces the treatment time because when you are concerned with aesthetics, at some point you would like to introduce a provisional, and being able to do an immediate provisional certainly reduces several weeks to months of treatment time. And I want to make a case for not just immediate placement with immediate provisionalization, but also early or delayed placement. So when you have a well-healed ridge, or if you're going in 6 to 8 weeks after an extraction has been done, I would still say that an immediate provisionalization on the day of implant placement again is very beneficial, as you'll see in this photograph. Again, this was a fully digital workflow of making this provisional, inserting it, and the benefit, of course, is it starts to develop the emergence profile for you, which was not existent when you suture around it. Additionally, in this particular case, there was both hard and soft tissue grafting that was done, so it really supported that hard and the soft tissue grafting, and additionally catered to developing that emergence profile. And of course, it reduces the treatment time again because now you can straight move on to an impression at this point. And once again, patient comfort or satisfaction with having a fixed provisional rather than having something removable. The biggest point I want to make, and it's not the focus of our presentation today, but really is about doing provisionalization, delayed provisionalization when there is, or immediate provisionalization when you're placing delayed implants in a well-healed ridge. So again, the case in point is if you have a situation like this where the implants were placed by me and I place these custom healing abutments. When you take these healing abutments, when you take these healing abutments out, you have a very circular sort of emergence profile. But it's very interesting if you compare the photo on the top that is for premolar and compare it to the adjacent canine, and you can just see the discrepancy in the overall dimension that a healing abutment really gives you. And the same thing for the photograph on the bottom, that's supposed to be a molar tooth. And if you compare it to the molar behind it, it is just so much tinier than what you would want your emergence really to be like. And so this is something that is very common. And these are photographs that I had taken from a lab that I work in, and they say this is something that's very routine. If you have an implant that has been placed and an impression taken directly from it without any development of the soft tissues, what you would commonly see is a crown looking like that has this huge concavity underneath the crown. And this, as you can of course imagine, is not good aesthetics and definitely not good for periodontal health, but this is something that is seen routinely. So even for a molar tooth, which is not a high aesthetic area, the photograph on the bottom is my goal, where the tooth really does have a proper emergence profile similar to that of the adjacent teeth, and somebody looking at it should not really be able to say that this is an implant restoration. And this includes both buccal, lingual, and interproximal emergence that has been developed in the bottom. So again, to compare those photographs on the left side, this is what the emergence profile looks like after it has been developed with provisional restorations, along with a ovate pontic that's been developed for the FPD. So I'm sure you can appreciate the difference and the importance of provisionalization even with delayed placement of implants. All right, let's move on to some biological and biomechanical considerations when we're talking about immediate implant provisionalization. Now, placing an immediate provisional on an immediate implant has become so popular today because of the developments in implant macrogeometry that have allowed, primary implant stability, which in return has allowed us to immediately load that implant. And in fact, as these pictures that you're seeing on the left side, histological studies have shown that the density of newly formed peri-implant bone at immediately loaded sites appears to be increased in relation to implants that were not loaded, so unloaded control implants, and this is after 3 months of placement. In addition to histological studies, histomorphometric analysis comparing immediate and delayed implants, delayed loading, also shows that there's no significant difference for overall bone implant contact. Nothing significant, but there is a significantly higher amount of bone between the threads in immediately loaded implants compared to delayed loading of implants. When we consider clinical outcomes rather than histological outcomes, there is still a controversy regarding whether dental implants should be subjected to immediate load or not. And from this arises the concept of immediate functional loading and immediate non-functional loading, which really is immediate functional loading means there's presence of occlusal contacts, and immediate non-functional loading means there's an absence of occlusal contacts in centric excursions. However, of course, this does not mean that there will be no loading in a non-functional loading situation. During mastication of food, of course, it is impossible to not have any forces on the restoration. It will still be involved in the masticatory process, but the concept is really about reducing the mechanical loading stress or strain in implants, single implants or multiple unit implants, but the ones that cannot be splinted in a cross-arch situation. Trukanovic and Albrechtsen did a systematic review to see, and as you can see, the meta-analysis shows that the differences in functional and non-functional occlusal load might not affect the survival of these dental implants. Also, there is apparently no significant effect on marginal bone loss either, whether you functionally loaded or do not functionally loaded at the time of placement. And an important concept to consider when we're talking about occlusal loading is really about controlling micromotion of the implant during its initial osseointegration, because a micromotion between 50 to 150 microns, and we know this really well, can negatively influence osseointegration and cause fibrous integration, so basically lack of osseointegration. And this is an important consideration between an immediate implant placement with immediate provisionalization versus an immediate provisionalization of an implant that is being placed in a healed ridge, so a delayed implant essentially. And that is because the mechanical leverage or the moment arm, as you can see on the left side, that can create micromotion is much greater in an immediate implant with immediate provisional scenario rather than a delayed placement with immediate provisionalization scenario. And of course, this is to be considered in the context that even if we have good primary stability on the day of implant placement and provisionalization, it is well known that old bone remodels to new bone around the implant, right? Or the primary stability changes to secondary stability. And between this, there is a stability dip, which can make an implant more prone to failure under excessive occlusal demands. So with that in mind, let's talk about basically developing your proper emergence profile or contours. So to me, the aesthetic success, and it has been really well sequenced out or listed out by Dr. Joseph Kahn and co-authors in this particular article that's referenced. But aesthetic success of any implant restoration, there's so many different factors. Of course, there are patient-dependent factors, such as what is the existing hard and soft tissue relationship at the time of implant placement, what is the gingival biotype, what is the sagittal root position when we're talking about an immediate placement of an implant. But there are several things that are clinician dependent that should not be ignored. So very importantly, three-dimensional positioning and angulation of the implant, contours of the provisional and contours of the abutment. Now, each of these, I think, can be a individual lecture. So today we're trying to focus on the contours of the provisional. When we're talking about contours, it's one thing is very important to remember is the crestal cross section. And if you go back to dental anatomy lessons and just think about what we learned in year 1 or year 2, you'd appreciate that the shape of any tooth at the level of the crestal bone and mucosa is very different than the circular shape of an implant. So as you can see, that residual root segment of that first premolar in the left side picture, right? And if you compare that to what a circular shape of an implant, as well as most healing abutments would be, and there's quite a discrepancy there. So developing a natural emergence of an original tooth requires going from that small diameter of an implant to either a triangular sort of cross section for the anteriors and a more trapezoidal one for the posteriors, and going from, again, those small circular healing abutments to a definitive restoration will very rarely provide a natural appearing restoration. So if you're thinking about a mandibular molar, let's say a first molar, and you decide to use a really large healing abutment, like a 7 millimeter circular diameter abutment, you may be able to somewhat achieve the desired buccal lingual soft tissue development, but very rarely the mesiodistal dimension. Again, like I said, the interproximal emergence profile is equally important for posterior teeth to prevent potential food accumulation areas, and it's not just about aesthetics there. So another very important consideration is, or thing to remember, is what's called the critical and subcritical contours of a immediate provisional, or any provisional for that matter. So critical contour is the most superficial area that will influence the gingival margin or the zenith location. Compared to that, subcritical contour is the deeper area which influences peri-implant soft tissue support and consequently the gingival color. The subcritical contour really should be as concave as possible in every direction, buccal, lingual, and interproximal. This allows, and this is during an immediate placement with immediate provisionalization, this really allows for the blood clot and any regenerative materials that we're using to stabilize between the provisional and the gingiva. On the other hand, the critical contour should be modified, especially for the facial surface, depending on where you desire your gingival margin to be. So in this picture that you see on the right side, it's from a paper by Martin Gonzalez and the rest of the team. And so you see number 8 here, or the right maxillary central incisor, is an implant provisional after an osseointegration and soft tissue maturation phase. In this, the critical contour can be brought more apically if we want to push the gingival margin more apically. Conversely, if you are in a situation where you're already noting some recession of the tooth and you're on the day of implant placement, gingival recession, of course, in that situation, you would want to have your critical contour as low as possible to allow for some creeping down of the gingival margin during the healing phase. With that, let's move on to some techniques that we can use for provisionalizing an immediate implant. So there are a lot of people who like to use a natural tooth. I have never been in a situation where I had a really good natural tooth that I could use. I more commonly see teeth that are either really fractured or, residual root segments. But if you have a natural tooth that you think is overall really okay, that's a great thing to be able to use as an implant provisionalization. And very importantly, the materials that we have available to us, like resin materials and whatnot, much more easily bond to the natural tooth, than other materials that they're not compatible with. So this is a paper that came out in 2015, and they really documented it well. So this is a natural tooth that they've taken out, placed the implant. With the natural tooth, what you're going to have to do is completely section off the root and make the tooth almost hollow, where you would have your temporary abutment coming out. And then also go ahead and develop more, toward in the transgingival area. You're going to have to add material to exactly how you would want your contours to be. And again, as I said, you can etch bond and use resin. What's very helpful if you're going to use a natural tooth is to have a putty index or some sort of a matrix that will help you reposition that tooth exactly where you had it before you place the implant. Once again, so you're going to add a temporary abutment or a custom abutment to the implant that you are trying to provisionalize, and then place the tooth around it and use some resin material to basically pick it up. And then eventually, chair side or in the laboratory, you are going to modify that subcritical and critical contours, as we were talking about, to be able to achieve the desired gingival margin. And then you can go ahead and inserted on the implant. So once again, I think natural tooth is a great, really, really good, method to provisionalize an implant. And if you are in a situation where you are able to, retrieve the natural tooth. More commonly, I am not. I really, really like to rely on some sort of CAD-CAM prefabricated shell, so a very quick intraoral scan that you can then design on whatever CAD-CAM technology that you have. And this prefabricated shell, and the reason I like this is because you can have the shell really, one that will fit into that area. Compared to this, we also have stock polycarbonate shells that are available to us. But the bigger challenges with these is they really are, one size fits all, even though they have a lot of variety, but they really are not patient specific. So of course, a CAD-CAM prefabricated shell that you're making from either a digital design or a wax-up is just going to be, an easier fit for that situation. So it really reduces the chairside time at the time of provisionalizing. So you can have, again, like I said, you can prefabricate this from a wax up, or if a patient has an existing provisional on a tooth that you're extracting, or even a definitive crown, you can try to use that. I think I have been able to successfully use a lithium disilicate crown by, again, making a screw axis hole through it. But of course, not able to do that with zirconia because that's very demanding, or a PFM crown. But provisionals or lithium disilicate crowns can also serve as good provisionals. When we're talking about abutments, again, we can have custom abutments that have been digitally designed for the patients, or you can have like a prefabricated stock abutment, which could be either a temporary abutment or a titanium base abutment. And of course, to make it cost effective, temporary abutments are the best way to go with that. Or you can have like a peak customizable abutment. So this is a really good paper that talks about a customized anatomic temporary abutment. So they take a peak abutment and they, again, add resin material and then reduce, develop their critical and subcritical contours to their desired area. And then they basically reduced it to be using this as an abutment, and then further developed a cemented crown over it, or they had that prefabricated. So I would really prefer my entire provisional restoration to be screw retained rather than cemented restoration, just because of concerns of cleaning the cement around an immediately placed implant that you have just grafted. So I'd like to not disturb that. So to me, a screw retained is always preferable. And other techniques that are available to you is just having a matrix that you can use, like a vacuum form matrix or even a putty matrix sometimes. But I can tell you that chairside, this is a lot harder to accomplish. You can also do this as an extraoral fabrication. If you have good stability of your implant, you can always go ahead and take a quick impression once you're done placing it, and then do an extraoral fabrication. And I'll show you one that I had done. So this is a patient who had a mandibular anterior tooth missing, number 25, and he did there was still residual root segments and granulation tissue in the extraction socket, which didn't quite heal very well. So when I opened this mucoperiosteal flap, the osteotomy sort of already was there for me. I did not have a lot of room to decide where I could be placing that implant, but thankfully it was at a very desirable position. You can see it's just a little bit more lingual, which is where I would want my axis of the implant to be coming out through. So this is the implant placement that has been done. When you close the flap and you take an impression. So this is a delayed provisionalization. When you take an impression, this is what you're going to see with a circular healing abutment. And again, this is not what's desirable to me. So I went ahead and actually this is what you would do, pour up a soft tissue model and develop the soft tissue on the model, and then go ahead and fabricate an extraoral provisional on this particular model. So the temporary, the provisional gets inserted, and you have really good emergence file 3 months later to take your impression. Today, I have moved on from any chair side, or most commonly not doing chair side fabrication or even lab fabrication, because we have all sorts of CAM technologies available to us today. So I want to discuss what is my current approach using static guides to make immediate implant provisional. So if you have a situation where that you are able to do a fully guided implant placement. That is, of course, the most important thing. Will this particular situation allow for a guided surgery? And first of all, will it allow for an immediate implant? Those are decisions that you need to, of course, make in the preoperative time. As you can see, this patient has this residual root, and very thankfully, because of that residual root, all the soft tissue morphology and everything has been maintained really, really well. So that has been a blessing. So we're not expecting to do, much more additional grafting at the time, other than hard tissue grafting in the jumping distance between the implant and the buccal bone. So when we designed this particular static guide, we could see that we do have residual buccal, that we have good buccal bone, actually, I would say, and this is just a case that would allow us to do a fully guided immediate implant placement. You have your guide ready to go. In the lab, that same guide can actually be used, on a model to place a dummy implant into the model, and this is the workflow that we adopt. We place a dummy implant, basically using the static guide, and just cure it with some acrylic around it. And this has, of course, been hollowed out. The tooth has been hollowed out, and then pour a soft tissue melange around it to the desirable extent, and that from there basically make a digitally designed provisional that is screw retained and ready to go on for the day of the actual implant placement. Your lab tech can also provide you a little jig for the correct placement. Now, it's very important, as if you are going to do a fully guided approach to this, then the abutment that you're going to have to use must be a non-engaging abutment, because the one thing that you cannot control is the timing of the implant. So when you're using a static guide to place an implant, do not use an engaging temporary abutment. So this is what it looked like on the day of the actual procedure. The tooth came out. We still have bone all around. We were happy about that. We went ahead and placed the implant using a fully guided approach again. This is the provisional that went in. This provisional had to be shortened because no matter how we adjusted, it was really had interferences during excursive and protrusive movements. So we shortened it, and the patient really agreed with it. He was walking around without that tooth for a long time. And of course, so another thing here is, as you can see, the gingival margin of that number 8 is a little bit higher than number 9. And so what we decided to do was really establish the critical contour a lot lower than what you see the gingival margin to be right now. And we expect that gingival tissue to creep down just a little bit while during the healing phase. Also remember that in an immediate extraction site, of course, because you've used your peritomes and luxators and whatnot, and just because of the inflammation, the tissues just are a little bit more, the socket is just a little wider than what you would want your final emergence to be. So even if you're doing chairside provisionalization, make sure you're not putting excessive amount of pressure on the tissues and just leaving that just a little bit, smaller in dimensions than your extraction socket. Let's talk about another case where it's really, really important to be able to do a fully guided approach. So here's a multiple unit implant placement. This patient came in with a 6-unit canine to canine maxillary FPD and was not happy with it, really desired some implant placement. So on the day of the procedure, we go ahead and have place implants using a guided approach. This was a situation where we were easily able to do that. You have the implants placed and you're ready to provisionalize them, and that's what it looked like. This immediate provisionalization for this case with four units supported by 2 implants and 2 individual provisional crowns on the canines. This took all but 5 minutes, and this is something that would be, according to me, just not a desirable chairside procedure to do when you have CAD-CAM technologies available to you. So this was a number 7/8 splinted on a number 8 implant and a number 9 and 10 splinted on a number 9 implant. Once again, this was fabricated in the lab, so it's very important to use a non-engaging temporary abutment. And the procedure was very similar. Once those guides were fabricated, there was a little bit of surgery done on the cast to remove the teeth. 2 dummy implants were placed, but the implants have to be, even if they're dummy, they have to be replicas, or you can use an abutment replica, is what I meant. You place those on the model and then go ahead and do your soft tissue moulage and fabricate the provisionals from that. And the real benefit here, again, is we could have given her another 6-unit tooth-supported provisional, but this patient now, after this implant placement and provisionalization on the same day, is ready after 3 months for us to be able to do impressions directly sent to the lab. And the soft tissue contours, as you can see, that have been developed by using this immediate provisional, is really, really well maintained, or much better, much bigger improvement, obviously, than what she had when she walked in with a 6-unit FPD. So again, very desirable to have some sort of CAD-CAM technology to you if you are going to be doing much more complex immediate provisionalization cases than just single units. So if you're not able to visualize, there can be several scenarios. Let's say your implant doesn't have the stability, or the occlusal factors really prevent you from being able to place an immediate provisional on the same day. What you can consider is what's called a custom healing abutments and an extraction socket here. So this is something that you can, again, keep modifying. Use a similar temporary abutment or a custom abutment, and basically use a resin material to develop that soft tissue that you desire to. And the benefit of this also is that once your soft tissues are matured and after your initial osseointegration phase, you can always modify your custom abutment, again, the critical and subcritical contours to be able to get to the correct emergence profile that you are trying to develop. This to me is also very beneficial for a posterior tooth at the time of implant placement, if it would allow for it, because of course I would not still want to, despite the literature, not want to immediately provisionalize a posterior tooth because of the excessive occlusal demands that provisional might have. So a custom healing abutment in a posterior tooth is also very desirable. And then you can see on the very right, you have a very good emergence profile that was possible with the already ridge. So with that, I'd like to say thank you once again to all those who attended this and to anyone listening to this presentation today.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facillitator